today. And it's my pleasure to introduce our very own Dr. Drew Sayre, who will present next. Dr. Sayre is an assistant professor in the Department of Nutrition Sciences at the University of Alabama at Birmingham. His clinical research relies heavily on the multiphase optimization strategy framework, and in particular, the sequential multiple assignment randomized trial, or SMART, experimental approach. Using these approaches, Dr. Sayre is conducting three, which is crazy impressive, 3 ongoing SMARTs with an overarching goal of developing efficient, effective, and personalized adaptive treatment strategies for improving the health and well-being of people with obesity. And so with that introduction, I want to say, Dr. Sayre, the floor is now yours.
Great, thanks, Rachel. So first, it's a lot of work doing 3 studies at once, but I have an incredible team and I really couldn't do it without them. I'll acknowledge some of them at the end, but let me see if I can get my screen sharing to actually work correctly. Let's see if I'm smart enough to do this. So, okay, can you all see my presentation slides, not my notes, hopefully?
Yes. Yeah.
All right. Very good. So thanks so much again for that introduction. I really am excited to be here presenting on this topic today, and the presentations so far have been really excellent. It's probably beyond cliche to say at this point, but I really wish I wasn't giving this on Zoom from a temporary desk in my unfinished basement. So I'm really ready to start doing stuff in person again, but nonetheless, here we are. So let's see if I can get started. Okay, so I want to start by giving you all just an overview of the ground I'm planning to cover in my talk today. I'll start by laying a bit of a foundation that broadly describes my overall research vision and the importance of fostering these strong collaborations with healthcare providers and clinics. Next, I'll briefly describe the importance of adaptive interventions in clinical practice, and then I'll spend quite a lot of time actually describing how the sequential multiple assignment randomized trial, or SMART, can be used to help create and optimize those. I'll give some examples of SMARTs in obesity research, including 3 pilot SMARTs. Again, so there's 3 ongoing studies, but they are all relatively small that we are conducting here at UAB. Then I'm going to throw a bit of a curveball at you, which is good because there has been a lot of talk today about challenging the status quo. So maybe it's not going to be so outside the norm to do this, but I'm going to start describing my evolving thoughts around how we determine the success in lifestyle-based interventions in people with obesity, and why I think it might be time to start de-emphasizing weight loss as our primary outcome, at least in some people. So with that, let's start talking about my overall research vision. So I'll preface this by referring to my last point, which is that I'm beginning to explore whether weight loss is the most appropriate outcome for improving health and well-being in people with obesity. However, assume that weight loss for a minute is the quote unquote right outcome, which is the commonly held view, obviously. If we make that assumption, I think most of the barriers to effective obesity treatment can be broadly grouped into 2 categories. The first is that we see this tremendous variability in achieved weight loss in our interventions, and we need to better identify the predictors and moderators of intervention response, and then subsequently tailor intervention strategies based on those factors. Second, most people will regain most or all of the weight they lose. We've seen this over and over and over again in our lifestyle-based interventions. So there's this generally recognized and accepted need that we need to do these long duration, multi-component interventions, which often start to resemble this kind of kitchen sink approach, or the black box approach that people have talked about earlier. The problem is that these interventions are usually unsustainable, both financially and behaviorally. And so within these kitchen sink interventions, there's a lack of understanding about the independent interactive impacts of the intervention components. And as others have mentioned, we don't fully understand if each component is effective, if it's ineffective or neutral, or maybe even detrimental to the overall program. However, I do believe it's important to conceptually reframe these barriers to effective treatment as being the greatest opportunities for conducting really impactful research. And so maybe not surprising given the theme of the symposium today, but I really think that the most framework is well suited to addressing these research opportunities within obesity. So before we really jump into SMARTs, I wanted to provide you all with a bit of context on the vision for my research program here at UAB and the settings in which we're conducting our work. So a figure like this is pretty straightforward, and lots of people give lip service to this idea of translating research into clinical practice, right? So I want my research to develop effective and efficient lifestyle-based interventions that can be translated over here into the clinic to improve the health and well-being of people with obesity, right? Then I want to close the loop by learning from the implementation of those programs and then back translating that into newer refined research ideas for further optimization. So this is all very much within the multi-phase optimization strategy framework, right? The goal here obviously is to create this sort of virtuous cycle of research to clinic to research translation. That's pretty easy to say and understand that conceptually, but in practice, as I'm sure all of you know, it's really, really hard to actually do this. And that's why I've labeled this as my pie in the sky research vision, right? So I want to give you a sense of what we're doing at UAB to put this concept into action, or as my good friend and colleague Holly Wyatt always says, she says, we gotta take that pie out of the sky and actually put it down on the plate, right? So first, the primary focus of the talk is that my research group is conducting clinical research related to obesity and weight management, mostly using the SMART experimental approach, but also we do have a couple of ongoing kind of traditional randomized trials going on. I am also, if I get this to progress, there we go. I'm also leading an initiative in our department to develop and validate a new construct that we're calling lifestyle wellness. This is a wellness construct that comprises some domains you'd expect, right? So it has nutrition, exercise, metabolic health, but it also includes domains like mindset, resilience, happiness, and satisfaction with life. We think those are at least equally as important. I'm also a co-investigator on a multi-site collaborative project called the International Weight Control Registry. This is led by Drs. Jim Hill here at UAB and Sue Roberts at Tufts University. The IWCR is kind of like a citizen science project where we, the supposed experts, are just asking people to tell us their stories related to weight management and tell us what worked for them, what didn't work for them. And then the idea is that we can help hopefully reverse engineer some new conceptual models and then start testing those for obesity management. So on the clinic side, the UAB Departments of Nutrition Sciences and Family and Community Medicine have been working together to create this really strong collaboration to help us put this vision into action. So first of all, Dr. Irf Asif, the chair of Family and Community Medicine, has developed a lifestyle medicine clinic that is housed within family medicine practice here at UAB. And this is actually where we're conducting most of our research. We have 2 ongoing SMARTs that are actually being conducted in the family medicine clinic right now. We've recently developed what we're calling a think tank to help ensure that nutrition science researchers and family medicine providers are regularly meeting and discussing the latest research, clinical practice guidelines, and then brainstorming on novel and innovative approaches for these lifestyle interventions. This last bubble, the idea repository, is something new that we're really excited to be launching here in a few months. And what we're hearing from our family medicine providers is that it's pretty common for them to have these like aha moments when they're meeting with their patients. But then those ideas tend to get lost in the shuffle of their daily practice and they don't ever really go anywhere. So what we're trying to establish is an easy to use system for providers to share these ideas when they have them just in the moment. And then the idea being that the think tank will select a handful of these ideas once a year for developing a new conceptual model for an intervention. And then we'll conduct a pilot and feasibility study to start getting the ball rolling on testing the components of that model. So I just wanted to spend a little bit of time sharing these slides with you all to give you some context on what our research group is doing overall and how the SMARTs fit within the bigger picture of what we're trying to do. So with that context and background, let's move on to the topic of SMARTs and how they've been designed to create and optimize evidence-based interventions. But first, we probably need to define exactly what is meant by an adaptive intervention. And I think this definition by one of the papers I shared, and side note, Rachel, I love the QR code. I need to do that in my presentations now. I was wishing I could do that in the moment, but it's too late. But anyway, so from one of the papers that I shared, they defined this as a sequence of decision rules that specify whether, how, when, and based on which measures to alter the dosage type or delivery of treatment, right? It's a mouthful, but I think it's really comprehensive. And clinicians make these decisions all the time with their patients. It's what they do, right? But it's not uncommon for these decisions to be made without a really strong evidence base. They're mostly oftentimes relying on their best clinical judgment. Additionally, the traditional gold standard two-arm parallel design randomized controlled trial is not well suited to building this evidence base because the participants are locked in, so to speak, to a treatment for the duration of the study. There's no adaptation for suboptimal responders. However, the sequential multiple assignment randomized trial was designed for exactly this purpose. This is what it was designed to do. So I like to think of SMARTS as being like, an experimental approach underneath the big most tent, right? So it is one particular design that is used within the overall framework. And as I said, the goal is to develop and test personalized adaptive treatment strategies. In a typical SMART, there are some exceptions, right? Study participants not achieving a predefined level of success at a predetermined time point are re-randomized to second stage intervention options. As I mentioned, there are some other types and variations to SMART designs, but most like the fractional factorial designs that were talked about earlier, I'm not going to get into the specifics of those kind of alternative approaches. And again, I think of SMARTS as helping to bridge that translational gap between the fixed arm comparative effectiveness trial and implementation science and clinical care. It has some really nice components of both, I think. So I think it does bridge that translational gap. Okay, so over the next several slides, I'm going to try to show you what a generic SMART might look like, and I've just generalized it to intervention A and B, right? And then try to introduce the analytic approaches that are commonly used when conducting a SMART. They start off simple enough, just like a traditional RCT. So participants are randomly assigned to one of two interventions. In this case, we're using A or B just as really simple examples. Then at some point, usually relatively early in the overall intervention period, participants are identified as being either an early responder or non-responder to the initial interventions. Typically, though not always, responders will then continue with their first stage intervention for the remainder of the study. So they just keep on trucking along because they're doing well, right? Non-responders, on the other hand, then get re-randomized to second stage intervention offerings that could take one of many forms. I've just tried to smash in a few different examples here, right? So you could potentially intensify the initial intervention, you could augment with an additional intervention, or you might switch to the alternate intervention. So you might go from A to B, or you might switch into an entirely different intervention, C in this case. So SMARTs kind of have these three inherent built-in aims for them. And I'll spend the next quite a few slides trying to work through how those look within an overall study design. But first, I've got to take a quick moment to acknowledge my good friend and colleague, Dr. Tappan Mehta, because he is really the brains behind the analytic operation here. I am not a statistician. Right. And I often joke with people that I only know enough about stats to cause a lot of problems. So I will just say I'll do my best to work through these aims, but just keep that in mind and take everything I say with a grain of salt, because I'm not the expert here on the analytics side. So the first SMART aim is what's called like the main effects aim. And there are analyses for both first and second stage treatments. So the main effect of first stage treatment seeks to answer this question: is it better to begin an adaptive intervention strategy with A or B? All right, relatively straightforward question. The main effect of second stage treatments then is conceptually similar, but is limited to only non-responders. So in this example, it seeks to answer the question: among non-responders to initial treatment, is it better to augment initial treatments with C or switch to intervention D? The second aim is called the embedded adaptive interventions aim. And this is the point where things start to become a little bit more conceptually complicated, right? So a typical SMART will have 4 embedded adaptive interventions, or AIs, as I'll call them throughout a lot of this talk. And those are essentially treatment paths that a participant could potentially follow. I'm going to walk you through these in a few slides to kind of show you what each of those looks like. But in general, this uses a replicated and weighted and replicated regression to compare 2 or more of those embedded AIs, or you can rank the embedded AIs from being most to least effective. The third SMART aim is called the optimization aim, and is where things start to get really interesting, right? So it's also important to note here that this aim is going to be exploratory and hypothesis generating rather than truly hypothesis testing. So the optimization aim uses a multi-step regression technique called QLearning Regression and has an overall goal of developing deeply tailored adaptive interventions. The objective here is determining whether treatment decisions ought to be based on baseline and/or intermediate tailoring variables that are not otherwise included in the embedded AIs of the study. And I'll spend the next series of slides trying to depict these aims within this general study schematic. So try to bear with me. So let's start with the main effect of first stage interventions. In this case, what we're doing is we're pooling all the responses from all three subgroups of participants who were initially assigned to intervention A and comparing those to the pooled response of all participants initially assigned to intervention B. Again, the question here is it better to begin an adaptive intervention strategy with intervention A or intervention B? The main effect of second stage interventions only includes participants identified as non-responders at that decision point, right? So now the question is, among non-responders to initial treatment, is it better to augment initial treatments with C or switch to treatment D? I should show up, switch to augment with C, switch to D. I'll get my animations right here. So just a few more notes about the analysis of the main effect aim. So first, I'm going to, again, wishing I had the QR codes, refer you to the papers that I shared with the symposium organizers. So we do have those available to you guys. The Almiral paper is a great overview of smart designs. They used weight loss as their example for application, so it works really nicely for me and my work. For those of you who are more analytically inclined, you may want to read the Nahum-Shani papers, which are much more in depth on the analytics side. So with that being said, the main effect aim is analyzed in the same way as the main effects in a two-armed longitudinal randomized controlled trial. It's simply a comparison of pooled outcomes from the subgroups pertaining to each aim. So once you get past what a smart design looks like and how complicated it looks, it's actually not that bad, not that complicated to analyze, at least in the main effect aims. Okay, so moving on to the embedded adaptive intervention aim. First thing I want to do is to help you visualize what each of the four embedded AIs actually looks like. So I'm going to go through the first one a little bit more slowly, and then I'll move a little more quickly through the other three. So the first embedded AI is to start with intervention A, and if they are successful, they will continue with intervention A through the duration of treatment. However, if they are unsuccessful, a non-responder, they would augment intervention A by adding C to the treatment plan, right? You probably noticed that I used a hatched box for responders, and that's because responders to initial treatment are shared actually by two different AIs. And this needs to be accounted for when you're estimating the mean outcomes of each AI. And you'll see this and how these are shared in the first two AIs on the next slide. All right, so the second embedded AI starts the same way with intervention A. And you can see here that those responders continue with A just like they did in AI1. So this is that sharing of non-responders issue that I talked about. The difference here is that non-responders to stage A are then switched to D rather than augmenting with C. The third embedded AI starts with B, responders continue, non-responders augment with C. And then the fourth embedded AI starts with B, but then switches to D. So I've just left the second stage intervention options highlighted here for simplicity, but hopefully now you at least have a little bit better understanding of how a SMART creates these different embedded adaptive interventions within the overall framework of the trial. Now, the really difficult part of an embedded AI aim is actually just estimating the mean outcome and standard error for each of the embedded AIs. Once that is complete, again, it's pretty straightforward to just make comparisons of two or more of those AIs or identify the AI that's leading to the quote unquote best estimated outcome. But there are two really important considerations for estimating the mean outcomes, the standard errors, and that is the underrepresentation of non-responders and the sharing of non-responders that I referred to a couple slides ago. So we use weighting. I say we, I mean TAPIN uses weighting to address the underrepresentation issue by giving non-responders a weight of 4. This is because they're randomized twice and therefore have 1/4 chance of following any given AI within the study. Responders, on the other hand, are giving a weight of 2 because they're only randomized once. So the weighting is inverse to your chance of following a particular intervention sequence. To address the issue of shared responders across AIs, it is necessary to replicate the outcomes for all responders twice in the data set prior to analysis. Once you've done this, though, you can just, again, use kind of standard methods for comparing two different embedded AIs. It's just the magic, so to speak, is really in being able to estimate those mean outcomes and standard errors. Okay, so lastly, we have the optimization aim, which usually generates the most interest and is the most, at least to me, conceptually taxing of the aims. So also remember that results from this aim are exploratory and hypothesis generating. I want to say you wouldn't ever, power your SMART based on the optimization aim, likely. But this is the aim where you get to start asking questions like, why was this person a non-responder? And gee, like, what if we had been able to assign that person to their ideal intervention? What would that look like? So this aim is it's pretty similar to a moderator analysis and a standard RCT. So for example, maybe you're testing for differences in response by sex or some other baseline characteristic. The primary difference with the optimization aim and a SMART is the consideration of both baseline and intermediate tailoring variables. So a really simple example, like treatment adherence, might be an example of an intermediate tailoring variable that might influence your decision points later on. So in this case, we'd be seeking to identify baseline variables prior to randomization that might help determine whether intervention A or B is better for that individual, but also identify baseline and intermediate or within treatment tailoring variables that influence the effectiveness of augmenting with C compared to switching to D. So you try to include both types of tailoring variables and then predict the optimal treatment strategy for that individual. So again, referring back to the papers here, so QLearning regression is the analytic technique for this aim. And I really encourage you to read the papers if this is really of interest to you. The second Nahum Shani paper, they have an entire paper dedicated to this. The data analysis method for constructing adaptive interventions is all about this technique of QLearning. But at the most basic level, I kind of think of it as, QLearning is this progressive multi-step regression procedure with each regression step being based on the results of the previous regression. So thinking about this in three basic, but maybe not incomplete or completely correct steps, right? So the goal of the first step is to identify baseline and intermediate tailoring variables that moderate or alter your treatment response. The second step then is to estimate the effect if a non-responder had been assigned to their ideal intervention. And then the third step then brings all participants back into the model and then predicts the best overall intervention sequence based on those identified baseline and intermediate tailoring variables. So it is trying to simulate what might have happened under the best of conditions. Okay, that was sort of a heady section, and I'm actually a bit ahead of time, which I'm surprised. I thought I was going to be way behind at this point. So I'm feeling pretty good about where we are. But hopefully I have a lot of time for questions here. So the next section, I'm going to introduce you to some examples of SMARTs and how they've been used in obesity research, including some of the ones that we're conducting here at UAB. So the first one I want to share is the Best Fit trial. This was led by Dr. Nancy Sherwood at University of Minnesota. It's funded by the NCI, and the primary results you can see were just published last year. So this is still a pretty fresh paper. So this is, again, one of the papers that I shared with the organizer, so you should have access to this. So in Best Fit, let me get a drink. Participants were initially assigned to either 3 weeks or 7 weeks of standard behavioral weight loss treatment. All right. The response criteria were appropriately different for each duration. So that was 2.5% for the 3-week arm versus 5% for the 7-week arm, because they were in this, in that first stage for twice as long, right? They included second stage intervention offerings for either a portion controlled meal, so augmenting the standard behavioral therapy with meal replacements, or switching away from standard behavioral therapy to a more acceptance-based treatment. That's what ABT stands for. So again, you should have access to this. So I'm not going to spend a lot of time going through the details of all the results, but briefly, I want to just I'll use this schematic to show you generally what they found, right? So first, they didn't find any significant difference in their main effect aims analysis, comparing both short versus long duration SBT, so there's no difference in their first stage main effect aim. Similar, there was no difference in their second stage intervention aim to look at differences between portion controlled meals, here B versus E, or B and E versus C and F. So there was no difference between portion controlled meals and switching to acceptance-based therapy. But they did find some differences between two of their embedded AIs. So this was, I thought, kind of interesting, was that they found that participants who received short duration SBT followed by portion controlled meals lost more weight than participants receiving long duration SBT followed by the portion controlled meal. So there's something about the difference in duration of the initial treatment that led to differences in their at their primary endpoints at 6 months and 18 months. So now I'm going to spend some time introducing you to 3 of the pilot smarts that we're conducting here at UAB, and then I'm really going to focus in on one of them towards the end here. So the first is supported by my KO1, so it's an example of how to get pilot work funded. I have this funded by a KO1 mechanism. This is from NIDDK. We call this study Press On, which stands for Protein and Resistance Exercise to Stop Sarcopenic Obesity Now. I did not come up with this, right? So I have some really smart people in my group that come up with really nice study names for us, right? So the eventual goal with this line of research is to construct adaptive intervention strategy for maintaining fat-free mass during weight loss. So not just weight loss, but really hanging on to muscle mass in adults like 50 and older who might be at risk for sarcopenic obesity. We start with counseling-based interventions, so relatively, I mean, they're intensive as far as counseling goes, but they're not, provision of food or anything like that. So they're relatively low-intensity interventions as far as obesity is concerned, to consume either a high-protein diet or to start engaging in regular resistance exercise. Then, if they're non-responders at that point, we either intensify the intervention or combine. So for intensify, this is either providing whey protein supplements to the high protein group, or this is doing 2 days of supervised exercise in the resistance training group. So then we're combining those strategies in the combined group. The second study we just launched for recruitment this month. It's called ADAPT, or Adaptive Dietary Strategies for Adults with Prediabetes trial. As the name implies, this is an adaptive weight loss strategy for prediabetes. So this is one that does specifically focus on weight loss as the decision point and main outcome. This is a weight loss study in adults with prediabetes. Starts with energy restricted diets of either reduced carbohydrate or high carbohydrate, which is a pretty common comparison to be using in obesity related studies. And then we either augment with a time-restricted eating paradigm or provide additional exercise support for non-responders. So we're adding on to those diet strategies to either eat during a specific time window during the day or to start engaging in additional exercise. So smart lifestyle is the one I want to spend a little bit more time discussing with you as we transition into the next section of the talk. And the focus for this line of research is on improving insulin sensitivity, not weight loss, right? So weight loss is not an outcome of interest in this study. So here we start with one-on-one individualized counseling with either a registered dietitian to improve diet quality or an exercise specialist to begin engaging in regular exercise. Note that neither of these initial interventions focus on weight loss at all. So it's not even a topic of discussion really. It comes up, but it's not one that our interventionists are preaching towards at all. Rather, what we're doing is including weight loss as a second stage intervention offering, not the outcome of interest again. The other option is to augment the diet or exercise counseling with a prescription for metformin, which, as I'm sure most of you know, is the first-line medication for diabetes management and was also used in people with prediabetes in the diabetes prevention trial. All right, so this is where if I haven't lost you already, I will probably lose you in this section. It's probably the last straw, especially if you're in the obesity research field. You're probably just going to check out completely, right? But I want to introduce a somewhat different way of thinking about obesity research and treatment and kind of explain why I didn't emphasize weight loss in the title of my talk and have instead opted for improving health and well-being. I'll be honest, this is the first time I've shared this thinking in a public forum, so I am a little bit nervous to see how this is received by people, right? So be gentle on me if you would. So earlier I presented slides on like the challenges and opportunities of obesity treatment and research. And in my mind, these are representative of that typical like inside the box thinking in this space, where the focus is on producing clinically significant weight loss, which a lot of people can achieve, but then also keeping that weight off for the long term, which the data show very, very few people are able to actually achieve this. So this has just got me wondering, is weight loss the right outcome? Or should we be thinking about other metrics for determining the success or failure of lifestyle-based interventions? So I'm asking myself questions like, is weight loss necessary or sufficient for people with obesity to achieve optimal health and well-being? Does resolving obesity, so losing weight and keeping it off, always improve health and well-being? And if not, for whom does it and whom does it not, right? So essentially, I'm beginning to view weight loss as a candidate intervention component within a multi-component lifestyle intervention, rather than the metric by which we determine the success or failure of that intervention. And so I'm sure there's going to be people in the audience, and especially if they're in the obesity field, that are going to disagree with this line of thinking. But much like the guy here in the park at his table, I'd love to continue this discussion and see what you all think about this idea about de-emphasizing weight loss in obesity research and treatment. The other thing I've been thinking about a lot lately is this phrase, right? I'm going on a diet. So what do people really mean when they say this to people and to me, right? I hear this a lot from my friends and family and my research participants. I want to go on a diet. Well, this is the first thing that I think of, right? It's this tangled up mess of multiple interventions, intervention components. And I think we really need to start, grabbing these strings and start pulling them apart a little bit and seeing what really needs to be up here in this big mess, right? But the other thing that always comes to mind right away is I think what they're usually telling me is I'm trying to lose weight, right? I mean, think about it. What's a typical response you give to someone when they're close to you and they say, hey, I'm going on a diet? I'll bet you either say, oh yeah, how much weight do you want to lose? Or you say something like, what? You don't need to lose weight, right? So there's been this, I think, society level conflation of going on a diet with needing to lose weight. And I think this is probably the right time for us to start deconstructing that conflation a little bit. But going on a diet also usually includes a diet quality component as well, right? You hear people saying, oh, I want to start eating more healthy foods. I'm going to, whatever that means, right? What does healthy foods even mean? I don't know anymore. I'm in this field, I don't know what a healthy food is, it seems like, right? Or you're going to start cutting out unhealthy foods. But all three of these strings are actually distinct interventions, right? You can certainly reduce your overall energy intake and lose weight without improving the overall quality of your diet. And you can start eating a higher quality diet without losing weight. So these things are not mutually exclusive. They are in distinct interventions. And on top of all that, most people also wrap up some sort of an exercise or physical activity component too, right? They want to start exercising more and spend less time in sedentary behaviors, but moving more and sitting less are additional distinct interventions. Reducing sedentary time is not the same as exercising more, right? So this is just one example of what I think we need to start doing with obesity treatment, and think about what are all the strings and what can we start pulling apart and seeing what really is driving the effectiveness of these interventions. So that brings us to Smart Lifestyle. This is a pilot study, very small, that we're hoping to start addressing some of these issues around reframing obesity treatment away from weight loss as an outcome, and also starting to disentangle some of these intervention components of what people mean when they say I'm going on a diet. So we're conducting this pilot SMART in just 40 people with stage 1 obesity, and the intervention target is improving insulin sensitivity. So this is what it looks like. So we're starting out again with that individualized counseling with either a dietitian or an exercise specialist to follow just dietary guidelines for Americans or the physical activity guidelines for Americans, but again, without a specific focus on weight loss. You can see here now that weight loss, this actually should say switch to weight loss instead of add weight loss, but they're switching to either weight loss as a second stage intervention, or we're augmenting with a metformin for non-responders. So this is adding a biobehavioral component to this as well. Just going to give you a little bit of some more methods and some definitions for smart lifestyle. So first of all, what is stage 1 obesity? For those who might know, so we follow the ACE guidelines on this. And so that is a BMI of 27 or greater and the presence of 1 or more mild to moderate obesity associated conditions. So it's not just saying a BMI 30 or above, it's overweight or obese plus having some mild to moderate associated conditions, mostly metabolic conditions. Participants engage in a total of 16 individual sessions with the interventionist. It starts out weekly for the first 5 weeks and then bi-weekly after that. This lasts for a total of 6 months. And again, there's a guideline-based prescriptions. Our response criterion is an increase in Quickie index score. So Quickie is at its core just a ratio of fasting glucose and fasting insulin. So the goal is to get a greater than 5% increase. And our a priori plan for this was to get about a 33% response rate. So we're pretty aggressive. So we're actually expecting 2/3 of people to be suboptimal responders. And again, our second stage offerings are weight loss using kind of the standard 500 to 750 kcal daily energy deficit, or to go to metformin using a pretty standard dosing procedure. So 850 milligrams once a day for 2 weeks, and then progressing up to twice a day at that dosage. And because this is a pilot study, as we've talked about a little bit, the primary outcomes here are feasibility related measures. So we have rates of recruitment and retention, session attendance, intervention preference, treatment expectancy and credibility, some other topics like that. So these are primarily feasibility and acceptability related measures. So we have done a pretty good job so far of getting this thing going. So we've enrolled 40 people. So we actually hit our recruitment target and went over by 1. We've had 35. So all people enrolled in the study have gotten to this month 2 time point, which is where we make the determination if they're a responder or a non-responder. Had 85% retention, so we're pretty good, but I think we could probably improve on that a little bit. We've had 8 total withdrawals in the study, 6 before that assessment and 2 since then. We've had 13 responders with our initial set of folks here, and so that's actually pretty close to what we predicted. Remember our goal was 33%, and we got about 32% of the total people enrolled, or 37% of those month 2 completers, so we're feeling pretty good. Another really important consideration, because we weren't intending to induce weight loss, was that we wanted to see, well, did we incidentally induce weight loss in people at that month 2 time point? So we did just some real quick analyses on that. The average you can see is only about a pound of weight loss, so pretty weight stable, but there is a pretty big range. In particular, there were 2 people who lost quite a bit in the first 2 months, but you can see there's also people who gained almost 10 pounds during that first 2 months. When expressed as a percentage of weight loss, there was about 0.5%. Again, a pretty wide range, but importantly, only 2 people kind of met that was sort of classically defined as the clinically significant threshold of 5% weight loss. So I think we did a pretty good job of keeping people mostly weight stable through the first stage interventions. So what are my plans with this, right? So how are we going to keep moving this forward? Kind of gets into the funding stuff, right? So we're going to have all of our data collected by the end of May. So we're really excited that that's coming up pretty soon. We're going to conduct our data analyses and feasibility assessments. We're actually planning to write a concept paper to bring in some of these ideas about how we're thinking about obesity, but then also co-presenting that with some of the pilot and feasibility data from Smart Lifestyle. And then, of course, the goal is to get someone to give us a pile of money to continue this line of research and do a fully powered optimization trial. All right, we're coming up to about 40 minutes here, which was my goal. I only have 1 slide on summary and conclusions, and they're pretty basic, right? So again, these adaptive interventions are really common in clinical practice, but the evidence base for creating and optimizing them is really limited. And the traditional RCT just frankly can't do it. It has its purpose, it's useful, but it does not build adaptive treatment sequences. Smarts, on the other hand, are a multi-stage randomized trial with the goal of doing exactly that, building optimal adaptive treatment strategies. Just some, like, maybe not conclusion, but some things to just think about. I really think it is time for us in the obesity research field to start thinking outside the box. And we need to really, I think, ask this question: is weight loss the most appropriate outcome of interest for these people? I have a lot of people to acknowledge for this work, obviously, but first I want to take a moment to really single out Jim Hill and Irf Asif. They're the chairs of nutrition sciences and family and community medicine here. It's really their shared vision for lifestyle medicine and their willingness to collaborate across our departments that's been really instrumental for me to be able to get this work going and do what we do, especially with those smarts being conducted in family medicine. So I wanted to acknowledge them specifically first, but then also we have this entire team of people that are helping us do this work. So that includes my KO1 mentorship, which includes Ken Sag. I just saw Ken pop up there on the screen. All of our collaborators, interventionists, and support crew, the entire Healthy Living Lab that Jim Hill, Holly White, and I have been creating over the last 3 years. We just have an amazing crew supporting this work. And of course, I have to acknowledge all the groups that are providing financial support for this work. So with that, thanks for your time and attention, and I'll be happy to try to address any questions. And you can, of course, email me if you have any follow-up questions as well. So I'll go ahead and stop sharing my screen now too.
All right. Well, so thank you, Dr. Sayre, for that amazing presentation. It was great to walk through SMARTS, and similar to listening to Dr. Guastaferro's talk, I was taking copious notes throughout the presentation. And it also looks like you have some obesity researchers in our audience today. And when you talked about that switch from weight loss as an outcome, it's like the primary outcome of interest, that really resonated with them. And so now we have an opportunity for all that are listening to ask questions. And of course, same as always, if you have a question, you can type it in the chat or you can raise your hand. And I already see some hands raised. So just as a reminder, if I ask you to unmute to ask your question, if you'll just say your name and the institution or department that you're with, that would be great. And I very top of my screen, Dr. Sag, we'll let you kick off today's questions. I see your hands raised, and then I'll go to some of the questions that are posted in the chat.
Thanks, Rachel. Ken Sag, UAB. Drew, that was really great, and your work in this area is really pivotal and leading the way at UAB. So thanks for all the great things you're doing. So as I listen about these smart designs, I guess the sort of natural thing that comes to mind is, why don't we do these all the time? I mean, this is the way we take care of people in the clinic, for sure, and it answers very relevant questions, but it really is about the cost and complexity. And ultimately, I suspect that's what limits us the most. I mean, it's hard enough to do traditional RCTs, and when you add more complexity, it gets even a little bit more challenging to keep people adherent to a particular strategy rather than just a single randomization. Can you comment a little bit about that? And I think what I heard you say is that your second level randomization is often underpowered. Is that the case, or do you think that we ought to be designing these studies with sufficient sample size and power to be able to answer the C versus D comparison that you proposed in the re-randomization?
So let me address the second one first, Ken. I would say that actually the most common way to power a SMART is on that main effective second stage interventions aim, which is what you said, that comparing. So among non-responders, is it better to do C or D? That's usually where it's power. Where I was saying that you don't typically have power for is in the third aim, which is that kind of exploratory optimization aim, like trying to figure out okay, Ken went through my study, but I found these tailoring variables about him. What should have been his best treatment sequence? That's what it's usually not powerful. That's the more hypothesis generating aim. You're right though. So getting back to your initial point about the complexities and I think the scariness, I think is a good word for smart designs, right? People look at them like, oh my gosh, like what is going on here? I was like that when I first saw them. I was excited and scared at the same time. And we were particularly interested in how our participants would react to this, right? So for instance, like we don't call people in our studies responders and non-responders, right? Like if someone's a non-responder, we don't say, oh, you're a non-responder, you got to do this other thing now. We say, hey, like you might benefit from an additional level of intervention. And so we're going to ramp up your intervention strategy a little bit to try to help you do a little bit better. And I was actually a little bit concerned that people might be like buying to be like a responder, like they may be trying like super hard early on so they get that quote unquote responder status. If anything, I think it's the opposite, because people know that those second stage offerings are available, and that's what they want a lot of times. That they're almost disappointed when they do too well in the initial interventions because they want to do the follow-on things like get supervised exercise and things like that. So And then I think, I think one of the other talks mentioned is that, there's a time and a place for SMART. So you're right, for trying to bridge that gap between, comparative effectiveness research and where that next step you want to be implementation, SMARTs fit really well in that space. But I'm seeing people, like I have friends and colleagues at other universities who I know have tried to use the SMART design framework to answer really mechanistic efficacy type trials. They want to kind of go after a real specific molecular mechanism and apply a SMART design to it. And it just doesn't work well in that sense. So I think there's like everything, there's a time and a place for these things.
All right. Well, I see that Dr. Marklin also has her hand up. And then after that, I have a question from the chat that I'll ask. So Dr. Marklin, if you want to unmute and ask your question.
Sure. Thank you, Drew, for such a great talk. I'm a huge fan of SMART trial designs. I'm not an obesity researcher, but my question kind of follows in on what Ken's question was about powering. And in your experience, I think you already answered the question, but would you plan for more dropouts in these non-responder groups, the arms that you are already pre-identifying as a non-responder by some metric? Is there a power consideration there for a dropout scenario?
Yeah, I mean, I think you've always got to consider the dropouts a little bit. I think because you're kind of getting into this idea of, are you doing a per protocol or completer analysis, or are you doing an attention to treat? And that factors into this as well. But I think that I was really concerned about what people would do if they were identified as a non-responder. I thought maybe we might have more dropouts at that point. But so far, fingers crossed, we've got a few cohorts that have been through these now. We're not seeing that come to fruition. So we're not seeing an abnormally large dropout rate in our trials compared to like a quote unquote traditional study. In fact, if anything, it's a little bit less. I think having that change up in the middle of the study actually keeps people more motivated to stay in. They want to see what happens next. I think that's actually, it keeps the study from getting stale. So.
Great. Yeah, I'm actually trying to do one of these, and I would agree with that. We call our optimization factor a booster visit. Like
that's good.
Yeah, like a booster session for these same reasons. But I also have been very concerned about dropouts, that it's so difficult to manage and plan for.
Yeah. Our biggest thing with dropouts has been that we're doing everything virtually. So all of our interventions are by Zoom instead of in person. That's impacted our dropout more than anything, I think. So.
Gotcha. Thank you.
Yep.
Yeah. So that's really interesting. I like that. It's a compelling thing to have people want to stay in because things stay fresh. I know. So one of the questions that was in the chat was actually talking about the obesity and some of the reframing side. And it says that this work is relevant and applicable beyond obesity and expands to other chronic disease states. Do you have thoughts on the benefit of relabeling to lifestyle wellness construct versus like decreasing obesity to increase initial enrollment? And so, Anne-Marie, I don't know if you want to also unmute and add more to that, or
Yeah, I hope I was clear. Anne-Marie Morides, the University of Utah. I just, I think there's a lot of times poor uptake in these studies if there's some self-stigma or perceived societal stigma. So I really love that construct. I've been looking at something similar, but labeled differently, because I just think we invite more people to the table. So I guess I was wondering, have you experienced that as you kind of relabeled this and got away from BMI and some of the standard measurements for optimal physical physique? How's that?
Yeah, so this you're getting at, I think, two kind of critical factors that could be standalone topics probably for a whole discussion. And I know we're cognizant of time here, but one is that I think this conflation of I'm going on a diet and nutrition in particular with weight loss, that limits the effectiveness or the impact, public health impact of nutrition related interventions, because people who don't have obesity often don't see like healthy diet as being something that's like for them, right? So I think a lot of people who don't have obesity would likely benefit from these lifestyle-based interventions, this lifestyle wellness construct, but don't see it as like a need for them because they're not overweight. So that's one issue. And then the other thing that's interesting, though, I think the reach thing is interesting. You would think so, but I think the issue here is that this societal norm around the expectation of being lean and skinny is so deeply ingrained that what people want is to be in a weight loss program. That's so if you're trying to sell a program, I would not sell and market a program that wasn't centered around weight loss, because that's what your customers want. That's what everybody thinks that they want and need. And so I actually think, if anything, it's trying to sell them on this idea that, obesity is just one factor that may be contributing to your overall lifestyle wellness. And there may be some circumstances where weight loss is the appropriate intervention strategy for you, but there are some cases where it may not be. And I think that's what we're trying to get to, but I don't think we're there yet, especially at the societal level. I think most people are still coming in looking for weight loss.
Thank you.
Thanks. And so with that, we're actually right at the end of this time for the third presentation. And so I just want to thank you, Dr. Sayre, for this incredible talk. And I feel like we could have many more hours of conversation, both behind the idea of weight loss and also about smart design. And so thank you again to the audience for asking excellent questions. We do have a 10-minute break that's coming up, well, less than 10 minutes, 9 minutes now. And then up next, we'll have the signature feature of our symposium, which is the Meredith Kilgore Endowed Lectureship by Dr. Linda Collins. And so I will see all of you at the top of the hour at 11 o'clock.
Great. Thanks, everyone.